Okay, ladies and gentlemen, let's get started here. This is week 4 of IHP 610. I've outlined the discussion questions for you. Many of you are doing a really good job with your discussion questions. You're answering all the material that's required of you. Some of you may receive deductions because you're not quite answering all the content and material required. If you're receiving deductions, I suggest you take a look at the outline that I provide in the lecture each week and you look at the rubric. As far as grading is going, I would like to remind you to take a look at your grades weekly. Make sure that you receive a grade for every assignment. Brightspace is a little bit different than was our previous Learning Studio. It does not notify me when new work is turned in after the deadline and after I finished grading. So if you see something that is not marked as graded and you've turned it in and submitted it, please send me an email, let me know, and I'll go back into the grade book and search out that particular assignment. So for today's discussion question, you're to look at Chapter 10, and you are to look at the two reforms between President Clinton's attempt for reform and President Obama's attempt for health care reform. And then you're to answer, why did the two reform efforts turn out differently? And then you're to look at what lessons from both attempts at healthcare reform can be applied to health law and policy efforts generally. And then you're to look at the other posts of your fellow students. In your response, consider the impact stakeholders had in the outcome of both reform efforts, and then answer, in your opinion, which stakeholders had the most significant impact on the outcome of each reform effort and why. Then you're to do a brief paper. It's an analysis paper. You look at state and local reform. As you well know, healthcare reform can take place at multiple levels. It can be both at the federal or state level and contained within the state level, local, or county level. Pretend that you're a policy aide to the governor, which would be you're making policy at the state level. How would you engage with key stakeholders to determine reform efforts in the areas of payment reform, medical malpractice, and patient access to preventative services? Should be prioritized in your state. So in other words, which would you prioritize as number 1, number 2, number 3, and then you're going to say why you've done that, and then you're going to identify the stakeholders that would be affected by your particular proposal, and then what would be the means of engagement with those particular stakeholders. And then for week 4, that is the extent. You have 2 assignments. Okay, so let's take a look at healthcare reform in the United States. Have we achieved meaningful and effective healthcare reform? Well, if I were to ask you this question immediately following the implementation of Obamacare in 2013, many of you would say yes, reform has been achieved. However, when we look at what has happened since the effective date of 2014, we see that we still have room for healthcare reform, and that there are many aspects of Obamacare that maybe were not well thought out and well planned. So what I'm going to do for this lecture, and I know it's difficult for people not to take sides, there are a lot of staunch Democrats that will say no matter what, that it is the best thing to ever happen for healthcare, and then there are on the Republican side that will say no, it's the worst thing to happen to healthcare reform and it should have never been passed. I'm going to give you some of the pros and cons, and we're going to look at some of the things that directly affected and impacted the healthcare system as a result of the passage of the Obamacare reform. Healthcare reform is not new. If we look back, federal government's been involved in healthcare reform since the time of President Nixon. One thing that we do have in common between both parties and independents is we do need healthcare reform. Spiraling healthcare costs, spiraling insurance premium cost, lack of coverage for those that have bought coverage through the exchanges and insurance companies, creating an underinsured situation, is still a major problem for the healthcare industry and for us as a nation. Our culture and lack of consensus about how we achieve healthcare reform and what are the goals of healthcare reform are directly affected by our distinct and different aspect of our culture, which is individualism and capitalism. And as such, those two have created the debate between whether or not we should have nationalized or socialized healthcare or continue on a free and independent system. Economics play a large role in healthcare reform. And we're going to see that the federal government does not have a requirement to balance its budget and has the ability to continue to borrow and put our nation further into debt. This is a real problem. And we have to make some policy decisions, and we have to make some decisions relative to our allocation of resources for what programs and what social policies we want to fund, and how much we want to fund it to the extent of. We cannot go unlimited in healthcare expenditures, and we cannot go unlimited in other expenditures in our system. And we cannot continue to borrow. That is a given. No matter how you think about whether or not we should cover everybody or whether we should only cover those who are productive in society, the reality is we cannot continue on the path that we are on with healthcare in the system that we currently have. When we look at state levels, most states, about 42% of the states, have a balanced budget act, which means they cannot borrow to fund and finance their health care. Healthcare actually started as far back as Teddy Roosevelt when he pushed for health care insurance coverage. And then when we look at the Nixon administration, he wanted to move more towards a preventative, move away from the fee-for-service expenditures and move more towards a system that based its expenditures on maintenance and improvement of healthcare of the nation as a whole. Well, as we know, that really didn't work so well, and we went up, and then we had another major, what you would call a reform, moving from the prospective payment system to a more cost-contained system, moving from the cost reimbursement system to a more cost-contained system, which we know as the prospective payment system. We then moved to the Clinton administration, and we look at the impetus and the push for healthcare reform in the Clinton administration. The politics and stakeholders in the 1990s were quite different from those in the time of the 60s with Nixon's push for healthcare reform. However, many of them did align in that the ultimate goal is cost containment and provision of reasonable care at a reasonable cost for all Americans. The way our constituency in any given political climate looks at healthcare reform will indeed impact and affect what reform is going to occur. And one of the problems we have is that depending on who's in power, Republican or Democrats, since the 2010 passage of the Obamacare Act, we really have seen a huge polarization, and we have seen a huge inability for the two parties to work together on any given legislation that really impacts our society. And that ranges from healthcare reform to immigration reform to reform in our prison systems. For some reason, we just cannot seem to get the two parties to come together anymore. And that is a real serious issue for healthcare reform going forward. Obama took a little different approach than Clinton, and Obama approached the various stakeholders and cut a lot of deals. And basically what happened was it loaded up the Affordable Care Act with a lot of things that were compromises to the stakeholders. A lot of the compromises that were made don't necessarily mesh and meet the ultimate goals of the Affordable Care Act. And actually many of these so-called compromises with the stakeholders created a situation where the act became too loaded with additional and extras, that many of them as conflicting goals created a situation where the industry now is in a serious situation when it comes to cost and premiums. The health insurance industry does not support universal health care unless the universal health care is provided through commercial companies and funded through the federal and state governments. So the only way you can get the commercial carriers involved is if they were to become the providers of the insurance that the federal government pays for. Lots of luck with ever getting that through. But if we do look at some of the goals of the Affordable Care Act, I don't think anybody would agree that these goals are well intended and somehow should be reinstated as goals for future healthcare reform, and that we should strive to achieve these future goals. The first goal of the Affordable Care Act is to protect families' financial health, helping them to avoid catastrophic cost and ultimately bankruptcy. Second goal was to make sure that health care coverage was affordable to the average person and middle class. The third goal was to aim for insurance coverage universality, and that is that the universality of the coverage would be that everybody gets the same level of coverage and same expectations from their policies. To provide for portability of insurance coverage, which was addressed in HIPAA, and the Affordable Care Act went on to reaffirm and try to extend this further. 5 is guarantee choice of health plans and providers. 6 is to invest in disease prevention and wellness initiatives. 7 is to improve patient safety and healthcare quality. 8 is to maintain long-term fiscal sustainability for those engaged in the exchange and private insurance carriers. I give you a table from your textbook in the mandates of plan required credible coverage. In order to be credible, it must meet all of those things stated in table 10-1. That was a one-size-fits-all product that is the only product that is available that would basically meet the Affordable Care Act requirements for credible coverage and to avoid the tax or imposed penalty for not having mandated coverage. In order for us to afford this system as the general public and as middle class, subsidies and those for the lower class, direct subsidies for purchase needed to be installed into the Affordable Care Act. The individual mandate created the necessity that all must have insurance coverage. That also included the lower income individuals in the United States. And of course, one asks, how can they afford it? Well, that is through the subsidy system. Your textbook has several tables in Chapter 10 that explain to you what the percentage of poverty level is and what percentage level will provide what subsidy and what out-of-pocket sharing expense from the federal government. I would take the opportunity to take a look at these because these are very explanatory of what's happening in our insurance coverage. The key changes to the private insurance market are that the Affordable Care Act mandated providing pre-existing condition coverage, that they had dependent coverage for children up to age 26 in all insurance policies, that preventative services were in fact covered, and that new health plans may not impose cost sharing for certain preventative services. So in other words, there is no co-insurance, no copay or deductible applied towards preventative services such as immunizations, healthcare screenings as delineated by the Affordable Care Act. The new Affordable Care Act also provided for coverage limits. It also provided a rescission clause that the plans cannot be rescinded unless it's a case of fraud. So in other words, once you purchase a plan, the insurance company cannot rescind that contract and cancel your contract. And then the last thing that was installed into the act was an appeal process. And the new health insurance plans must have an effective appeals process that includes an external review option. And Obamacare has many positives, and I've delineated those positives in your lecture. First positive is guaranteed issue and renewability of insurance policies. It has a limitation on rate variation in policies, so you don't have markets that have one huge policy premium and other markets provide for a lower policy premium that does not provide credible coverage. The coverage also is limited in how much you can increase in the dollar limits of coverage. The fourth is essential health benefits. 5 is wellness plans. 6 is insurance companies can no longer deny anyone coverage for pre-existing conditions. 8, states must set up insurance exchanges or use the federal government's exchange. Either method makes it easier to shop for plans, and it was designed to provide for transparency and easier navigation of the systems that were created. The middle class, earning up to 400% of poverty level, receive tax credits on their premiums. It expands Medicaid to 138% of the federal poverty level, and it provided coverage to adults without children for the first time. It eliminates the Medicare donut hole for gap in coverage for prescription D drugs. On the other hand, some of the faults of Obamacare are: 1, 3 to 5 million people lost their coverage through their employer-sponsored plans. Many employers decided it was either pay for higher premiums and provide coverage directly for their employees, or turn to a system where they provided credits or paid stipends to their employees for them to seek and obtain coverage through the Obamacare exchanges. 30 million people never had company plans and relied on private health insurance. Many insurance companies canceled the plans because the policies didn't cover the ACA 10 essential businesses. So in other words, a lot of the plans were canceled because they could not meet the credible coverage requirements of the Affordable Care Act. So many insurance companies moved out of and away from providing that coverage. The third issue with Obamacare is it increased coverage and increased the overall health care cost in the short term. Many people receive preventative care and testing for the first time. However, once they were diagnosed, treatment could become expensive for those on the bronze and silver plans in the middle class because of the high deductibles, high copays, and high coinsurance. Another problem with it taxed people who didn't have coverage through the Affordable Care Act or exchanges or through a private carrier with credible coverage. And what happened with this situation is many people were paying fines that could have otherwise gone to healthcare costs and expenses. 4 million chose to pay the tax rather than pay for the coverage. They estimated the total amount paid was $54 billion. If we were to start to look at the cost of the Affordable Care Act, this didn't even make a dent in subsidizing or covering the, not subsidizing, but covering the subsidies and payments to individuals to make sure that the low class were able to meet their medical expenses. Starting in 2013, medical device manufacturers had to pay a 2.3% excise tax on all medical devices. A lot of people don't realize to this day and didn't really take into consideration, but if you look at in 2013 what it cost you for a pair of contacts or a pair of eyeglasses, you will note that it was 2.3% more expensive starting in 2013 than it was in the previous year. Also, one of the bad things about Obamacare is that pharmaceutical companies were required to pay a subsidy tax in 2013 through 2023, and that was estimated to be an $84.8 billion tax. That is one of the things that has stifled some of the R&D in the pharmaceutical industry and has been the source of much controversy relative to whether or not the pharmaceutical companies are indeed making too much money and should pay more taxes. But many view that as a negative of Obamacare. In 2020, insurance companies are assessed a 40% excise tax on Cadillac plans. So in other words, people who have a quality excess, what is considered excess of approved coverage from the federal government, once you hit a certain level of care and benefits, your plan is now considered a Cadillac plan and you are taxed on having too good of a plan. And of course, those 40% taxes will be passed along in premiums and deductibles. And then the last thing is the spiraling premium rates, and I've given you some examples of premium increases in the double digits. We actually had a couple of places that no longer have care through the exchange. Many of those places were experiencing double digits in the 75 to 100% range of premiums. And those underserved areas are now without any credible coverage through an exchange in the Obamacare system. Some of the legal and operational challenges that we see relative to Obamacare is the insurance premium rates. They are skyrocketing, they are spiraling upwards. We don't know where it will end. We don't know if the ACA would or will ever equalize or stabilize those premiums. It doesn't appear likely to happen. The functionality of the exchanges, not only did we have functionality issues with the exchange website and the government website when it first came out, we are still experiencing technological changes to the systems to try to address those which are very costly, which exchange providers did not consider into the overall cost of becoming a carrier under the exchange. The last thing I want to point out is the way the Obamacare plan was pushed through the United States government has created a polarizing situation between the Democrats and Republicans. We see, as a result of the way it was passed in the 2010 midterm elections, we saw a huge voting anomaly. Normally you will see a change in not ownership, but leadership, or which is the predominant house. Depending on midterm elections, usually you will see a SWIP swap. Not only did we see a SWIP swap in the midterm elections of 2010, we saw an overwhelming change in the 70% range, which is extremely unusual in American politics. This suggested to many that Americans were not satisfied with the way the Democrats handled the passage of the Obamacare. Again, depending on which side of the aisle you're on, you will have a contrary position to that, and I understand that, and everybody's welcome to their position on that. I would just state that that is one of the things that has been pointed out as a result of the way the Obamacare Act the way it happened. The 20 hours debate limitation to the Affordable Care Act in the House and Senate floors was extremely unusual for such a large and dramatic change in American healthcare policy. However, the Democrats changed the rules and limited debate to 20 hours. The final draft of the bill was not presented to the senators and congressmen until the day of the election. And everybody remembers Nancy Pelosi's famous line, "We have to pass the bill so we may find out what is in that bill." Well, that created a lot of dipolarization and consternation on the part of the Republicans, which evidently they have not forgiven the Democrats for. And then, of course, now what's going on, the Democrats are extremely opposed to Republican efforts, and the Republicans are opposed to the Democratic efforts. So I have no idea where we are going with healthcare reform. I can tell you healthcare reform is going to be very difficult in the United States because of what we call path dependency, and that is basically a theory that holds that once we have something so well ingrained into our policy and into our system, we are reluctant to change or go off of that particular path. Health reform is impossible if we continue with the polarization we have in DC. I want to point out three key rulings in the Sebelius with the Federation of Independent Businesses versus Sebelius et al. And that is, it upheld the individual mandate. It also upheld the penalty assessed for not having credible coverage. And it also it turned over the government's ability to force the Medicaid expansion through the various states, and it limited that particular provision. And then if you consider the following issues that have dominated the political landscape at one time or another since the Affordable Care Act was signed into law, you will see that the act still has a lot of opposition. Some states have readily adopted and welcomed Obamacare. So we have a famous quote, a union divided cannot survive. Are we to the point where we have a union that is divided? I don't know. We're getting very close. Another issue that has become forefront is the unsuccessful experience with state insurance marketplaces. Some, I will point out, have had successful experiences. It depends on where you sit and what your needs are. There's been extensive litigation relative to Obamacare, and we continue to see lawsuits work their way through the courts. We've had delay in enforcement of employer mandates. We had state-level insurance regulation for accountable care organizations vary. So what we're looking at, ladies and gentlemen, is a very uncertain future for Obamacare and for any health care reform. We do know that it is very likely that this current administration will whittle away aspects of the Obamacare Act, such as the individual mandate. There are other positive things that the administration has done to try to implement change to the healthcare industry without necessarily complete repeal at this time. And that is, for example, we have now the ability to purchase through association coverage different policies, and those are allowed to cross state lines. So we have intrastate ability to purchase at this particular time. We also have just seen a recent law signed into effect by President Trump that says pharmaceutical companies must advertise the price of their drugs on their commercials. And the second aspect of that law, he didn't sign it yet, it's proposed, I take that back. And the second aspect of that legislation is that the pharmaceutical companies and drugstores must offer a alternative in the form of generic with a clear price designation. We will see if that passes or not. With that, ladies and gentlemen, if you have any questions relative to this week's work, more than free to call me at 801-940-2531 or email me at p.vanash@snhu.edu. Thank you, ladies and gentlemen. Have a good day.